Hello, everyone, and welcome to our special two-part series focused on all things menopause. Many of you know Dr. Tracy as you follow her on social media or may have attended one of her very hilarious in-person sessions. Today, she'll be sharing her invaluable insights and answering most of our frequently asked questions and mine on perimenopause and menopause. My name is Jennifer Hufnagel. I am 46. I have a uterus, and I've just started using the words perimenopause. And my role here today is to ask questions and to support the technology, making sure we can smoothly bring this valuable information to you online. So, for those of you who don't know Dr. Tracy, after she graduated from medical school in 1997 at Memorial University of Newfoundland, she completed her residency in obstetrics and gynecology at Dalhousie and with admittance to the Royal College of Physicians and Surgeons in Canada in 2002. She currently lives in Comox, which is in British Columbia in Canada, for those of you who are outside of Canada listening in, with her two children, and we are so thrilled to have her share her knowledge with us today. So, are you ready to get started, Dr. Tracy?
Oh, absolutely. I'm really grateful that you're here and doing this with me. So thank you.
Oh, you're very welcome. Thank you. So let's dive in. So I think a good place to start is with the why. You started a Facebook group called DeadLadyBalls, which is a great name, by the way, and we'll make sure that we link it in the show notes when we upload this video. Really to raise awareness on menopause and perimenopause and create a supportive community of women. So I understand now you're returning to clinical practice again. Yay!
Yeah,
And you'll be primarily focusing on menopause. So, can you tell us a little bit about why you chose this path and why now?
sure, absolutely. Well, I practiced general obstetrics and gynecology for about 20 years, including surgery, maternity, and the full scope of practice. And when I look back on my training, there wasn't a huge amount of focus on menopause. It was like if you were lucky to see a few patients in clinic and get a little bit of teaching, but we didn't have a formal menopause training program. Um, and so really, it was also pre 2002, and that's a significant year because that's the year the Women's Health Initiative was published. Prior to 2002, lots of women who were going through menopause were on hormone replacement therapy. And when the Women's Health Initiative was published, and for those of you who aren't aware of the WHI, and we're going to get into that in a lot more detail in part two. But the bottom line is it was a very large study looking at the risks of hormone replacement therapy and benefits in much older women. And there was a media sensation after this study was published, talking about the risks of cancer, heart attack, and stroke. And it raised a lot of fear, not just in women, but in clinicians, in physicians. And prescribing of hormone replacement therapy basically dropped off a cliff.
Mm.
And that happened as I was graduating. So I recognized that there was a lot of women who were afraid to take hormones, suffering a lot with menopause, and none of us really knew what to do about it. So menopause came into sharp focus for me in the very first year of my practice. And because I'm someone who generally practices medicine from the perspective that you learn a lot from your patients,
Mhm.
they're really your best teachers because they're the ones who are going to teach you if what you're doing works or if it doesn't work. And it's their lived experience that you learn from. I really recognize that the medical model I was trained with wasn't sufficient for me to be able to provide the type of care that I thought these women deserved. And so that was one aspect of it. But then I went through menopause myself
Hey.
and I was quite young. I kind of went actually from postpartum to perimenopause, which
Oh,
a lot of women do. And it's like the postpartum that never goes away. And then you kind of realize, wait a minute, I think this might be menopause. And even as a gynecologist, I wasn't taken seriously. I was told I was too young.
mm,
And there's nothing like experiencing yourself to really understand the impact that it has on people. So, and I also noticed in my practice that it was really difficult to get these patients in because there's always so many urgent things that come up that menopausal patients kind of get moved down the list. And a lot of gynecologists have a year wait list to see people. And honestly, if I had to wait a year to get help, I wouldn't have been able to work. I wouldn't have been able to function. My kids would have suffered. And so I really wanted to change how difficult access could be and do whatever I can to increase education and knowledge and awareness around menopause.
And we're just so grateful for that. I know you talk about this difficulty for patients, so I think this is a ripe time to be able to have these conversations and it be okay. We're hearing more and more about menopause and perimenopause on social media. So thank you so much. So next question. So you started your practice around the same time as the Women's Health Initiative came out. So what was your experience and what have you really noticed and what has really changed over the last 20 years?
Well, sadly, it hasn't changed as much as it should have. Like, there are times when I look and think that study came out 20 years ago, and we are still suffering from the after effects of it. And, I think Jen Gunter put it this way, like, once you ring an alarm bell, it's really hard to unring it. And so the study got a lot of attention, but the fact that the study was dismissed, debunked, re-evaluated, new evidence came out that was really helpful. The old thought that hormone replacement therapy is dangerous has really persisted. And it just seems to me that because of that fear, we sort of we overstate the risks, and it leads to a lot of women really suffering unnecessarily and difficulty in getting good menopausal care. And even the women who choose to stay on hormones often have this in the back of their head thinking, like, am I doing something wrong? Is something bad going to happen to me if I take this? And it's a huge barrier to good care. And from my experience, the literature doesn't really, the studies we have out there, they don't really reflect what women's actual lived experience of menopause is. And it also doesn't give women enough credit to be able to make their own decisions about risk for their own health and well-being. A lot of what we do in medicine has risks. For example, if your knees wear out and you're getting a knee replacement, that's a risky surgery with a long recovery. And it's not life saving, it's life altering, but it's not life saving. But we allow patients to accept that risk for the benefit that it gives them. And that doesn't always translate over into menopausal care. It sometimes seems that people are saying, no, hormones cause cancer, it's bad, you don't need it, menopause is natural, it goes away, just carry on. And the difficult thing for me about that is, okay, yes, menopause is a natural transition in life, but it doesn't come just as, oh, you go through menopause. Like, 90% of women have symptoms. And for a lot of those women, those symptoms are debilitating. So, and it can last years and years and years. So if we're ignoring all of that, we're sort of focused on the risks of HRT, which are not as well defined as we think, but we're not actually talking enough about the risks of not treating menopause. And you have a whole group of primary care providers like family doctors and nurse practitioners. Now, I'm well aware that there are some primary care people who really don't care about menopause and
Right.
won't address it. But I also think there's a lot of primary care providers who really do care about it, but they don't have the knowledge, the tools, and the expertise to know what to do. And the information can be really misleading. And so, it's a difficult position to be in, um, to try to, increase education and awareness with primary care. So it makes it difficult for women to be able to access good care. And it's not just primary care. There are gynecologists who women go to and get told, no, you shouldn't take hormone replacement therapy. Um, and, as for the whole natural thing, just because it's natural doesn't mean it doesn't require medical attention. Cancer is natural, heart disease is natural.
Mhm.
And the other thing I hear is it's not a disease. And I say neither are gunshot wounds, but that needs medical attention too.
100%.
So there, thankfully, because 20 years has gone by, and I think the proportion of the population of women that's in menopause is bigger than it used to be. Women are starting to actually say, no, like, this isn't good enough. So there's starting to be a bit more talk about menopause because menopause has always had this like little blanket of shame and stigma and aging. Like women will say, like, once you're 50, you're irrelevant, you're invisible, nobody cares about you anymore. And nobody wants to go around saying, I'm in menopause because it has a lot of stigma. But actually, now that we're starting to see more and more books come out. There's CBC has done some work on it. We're starting to recognize the impact in the workforce, that there's actually fiscal consequences for menopause. And it doesn't happen in a bubble. Like it affects our partners, our colleagues, our ability to work. Everything is affected by it. And so I'm really grateful to see that, yeah, it's been too slow, but the conversation's actually getting a bit of momentum in the last little while because women need information and answers. And what we're doing right now is not adequate.
Yeah, no, 100%. And I think there's also a little bit more empathy around, especially in the in the workforce. Maybe this woman is going through perimenopause. So the conversations, the empathy that's happening out there. And it kind of amazes me that you had said something, this is something we all go through. 100% of women go through this.
Mm-hmm.
And here I am, 46, just on my learning journey of perimenopause. I've just started saying that in the last really few weeks since we've been talking and working together. And I'm frustrated and I'm confused about how so many of us don't know what's coming. We're not prepared for it. So, can we maybe just talk a little bit about the basics of menopause? How do women know when they're going through menopause, perimenopause, how it's defined, and just sort of start with like menopause 101?
Mm-hmm. Yeah, because if you don't know how we define it, it's really hard to know if you're in it or not. So the thing about menopause, it's not, it eludes definition in some ways. So I like to say, you know how when you're listening to music, some songs kind of end with a boom, boom, and the song is done. And other songs do that really slow fade out at the end, and at some point it's over. Menopause is like that. It's you have normal ovarian function, and then slowly your ovarian function declines. And at some point, we say you're in menopause. So the best definition is no period for 12 months, which means you have to A, have a uterus, B, not have had an ablation or an IUD that stops your period. And even then, you don't know you're in menopause until you've been in menopause for an entire year. So
Right.
it's a retrospective thing. So, in truth, for women who don't bleed, there is no clear definition. So basically, you can be as young as 40 to 45, and that's normal to be in menopause. Younger than 40 is considered premature ovarian insufficiency, and that's a whole different ball of wax. But that's when you hit menopause. But leading up to menopause, there's a very long process called perimenopause. And that's when you go from normal cycling menstrual cycles to slowly dipping into ovarian failure. And that can last 5 to 8 to 10 years. And for most women, that's the most challenging part of menopause
Mhm.
because the symptoms are not consistent. They're all over the place. Like it's kind of like the weather in Newfoundland. If you don't like what's happening, just wait 10 minutes and something different will
Right.
come up.
Yeah.
And it's really confusing. And because perimenopause can last 5 to 8 years, if you're destined to be menopausal at 42, you're perimenopausal in your mid 30s. And
Right.
so women in their mid to late 30s who have a lot of hormonal symptoms are often dismissed with the you're too young. And that's a real problem. So it's kind of it's a challenging thing to know when you're in it. But basically, if you're in the right age group, you're over 32 to 35, and you have some of the hormonal symptoms that are happening, chances are very high perimenopause is part of the picture. And, then there are women who go 10, 11 months without a period, and then they get another period, and they're like,
So,
do I have to start over? Well,
Yeah.
kind of technically, yeah, because that's the definition. But I mean, for all intents and purposes, you're in menopause.
Right.
So, like, for example, I had an IUD. I didn't
Mhm.
get my period. So, even though I am educated about menopause, I didn't really know. I blamed my job. I thought I was crazy. I thought I was stressed. And then finally it clued into me that, wait a minute, this is a little bit more
Something.
than that. But I think there's a lot of symptoms that women don't recognize are actually symptoms of perimenopause. And one little thing, like every now and then you'll talk to a woman who says, I don't really know what the big deal is. Like one day my period stopped and it was nothing. And I used to joke at my talk saying, resist the urge to punch her in the throat, nod
Yeah.
and smile and walk away because great, but that's 90% of us, that's not what we experience. And for many of us, the symptoms are actually debilitating.
You know what? And the just being in denial, I think sometimes too, right? So whether it's I don't want to feel like that shame piece around it, I'm not in perimenopause, I'm not in menopause, or you talk to your parents and your mom is like, I never went through that, I'm fine. Well, were
Oh,
you?
it's like that Baroness Von sketch thing where she was like, but I have a snowboard. Like, how could I be in menopause? I'm too young. Yeah, and that's the stigma and the shame piece that I was talking about. And when you have a population of women who don't, like we talked about earlier, they don't know what to expect. They don't necessarily know what symptoms they're looking for. It can be pretty confusing.
100%. And, talking about symptoms, so everybody knows about hot flashes. And I'm super thankful yet. Maybe I won't be one of those women, but maybe I will. I don't have hot flashes yet. I have other symptoms, but not hot flashes. So there are so many, and so many of us that we're not aware of. We might be questioning, is this perimenopause? Is this menopause? Is this related? Or am I just going batshit crazy? So can you talk about the symptoms that might alert us to the fact that we might be in perimenopause?
For sure. Now, this is a question I could probably talk about for a half an hour, so
Right.
I'm going to try to be brief. But here's the
Okay.
thing about hot flashes. They command attention. Like they're obvious and you can measure them. So the literature and the medical community love hot flashes because it's an obvious thing, whereas mental health symptoms different. But there's so a lot of women will go to their doctor and get asked, well, I think my hormones are off. Well, do you have hot flashes? And if you say no, it often you'll get, well, it's not menopause. But not all women get hot flashes. And for some women, it's later in the course of menopause. So just very briefly, and I have a longer video about this on my Facebook page that's probably boring because it's 30 minutes, but it gives you a bit more detail. But if you know a little bit about what happens in the normal cycle, it can help you with figuring out when things are going different. So if you just finish a period and your body is gearing up for a new cycle, your brain produces a hormone called FSH. And this is going to be important a little later. We'll come back to it, but it's called follicle stimulating hormone. And it's basically your brain telling your ovaries to make eggs. So your ovaries start producing eggs, and those little follicles, as they're developing, they secrete estrogen. So in the first part of your menstrual cycle, you get this nice flush of estrogen. And most women will describe that first week to 10 days after their period as their best time in the month. And then a little process of microselection happens. One egg gets picked to be the egg, and you ovulate. Now, around ovulation, you can get a little dip in your estrogen. And then after you ovulate, when the egg is released, the follicle that released the egg produces progesterone. And you only get progesterone in significant amounts in your bloodstream between ovulation and your next period. So estrogen has been building the lining of your uterus up. And after you ovulate, progesterone stabilizes that lining, gets it nice and rich for a pregnancy. If you don't get pregnant, your progesterone levels fall and your estrogen levels will fall right along with it. And it's the drop in your progesterone that causes the bleeding to start, and then it repeats.
Right.
So given that, like, and progesterone, I kind of call it the hungry, angry, moody, punch your partner in the face hormone because it's kind of implicated in PMS and
Right.
PMDD.
Mhm.
So when you look at what's happening as your ovaries are running out of eggs and the quality of the eggs that you have remaining isn't great, because even before we're born, we have a set number of eggs and we lose most of our eggs before we're even born. And there's only so many, and when they're gone, they're gone. So as that process is happening, what happens is a lot of women will say, I get my period, I feel great for a week to 10 days, and then it's almost like a veil comes down. So most of the symptoms of anxiety, mood changes, those things will happen in that second half of the cycle. And with the little dip in estrogen that happens around ovulation, if it gets deeper, some women will have night sweats or will get headaches or a little bit of spotting. And then with the drop in estrogen right before their period, you can get night sweats that only show up in that little short window, or menstrual migraine or headaches. And the disruption in the estrogen and progesterone causes a lot of mood changes, irritability, and those sorts of symptoms, which often get treated like a primary mental health issue as opposed to a hormonal issue. Like PMDD is in the Diagnostic Compendium for Psychiatric Issues, and I personally think it's more of a hormone thing.
Mm-hmm.
So when all of that process is happening, you know how I said the progesterone is what manages the lining of your uterus. Well, as those hormones go off, the lining of your uterus gets disrupted. Ovulation starts happening irregularly. So one of the early signs is a change in your period, either a change in the flow, the duration, the frequency. You get a period 3 weeks, 6 weeks, 6 months. But you can have significant perimenopausal symptoms and still have bang on regular menstrual cycles. So I tend, like, this is always a depressing list to give people, because it's like every part of your body is affected by menopause. So changes in your hair texture. I joke, like your face starts trying to slide off your head. There's dental changes that happen. Women complain of itchy ears, ringing in the ears, headache, visual changes, changes in taste, changes in digestion, skin changes, mental health symptoms. I mean, it's frustrating for me. I'm reviewing the North American Menopause Society guidelines, and the first thing I look for is their whole section on mental health, and there isn't one. It's basically under other medical conditions, and they talk about it like it's a psychiatric issue. But for so many of my patients, the thing that makes them seek medical care is the mental health symptoms, and they often get offered antidepressants or anti-anxiety medication, which is challenging because those drugs have side effects that are already symptoms of menopause, like weight gain and low libido. So loss of lean muscle, difficulty recovering from exercise, change in your body composition. Even if you weigh the same on the scale, you feel fluffier because you have more body fat, less muscle, fatigue, joint pain, muscle aches, loss of sexual interest, vaginal dryness, urinary frequency, pain with sex, vaginal infections, bladder infections. The list goes on and on. While at the
Constipation.
same time, yeah, you're losing bone at an accelerated rate. Your risk of heart disease increases at the onset of menopause. Your risk of diabetes increases, and your metabolic needs change. So what a lot of women say is, I haven't changed anything, but everything is changing. And I'm like, well, your body is not the same as it used to be. You were reproductive with normal hormones, and now you're not. So you have to make changes to adapt to where your body is actually going. Um, and a lot of women get told they're too young, and that's really dismissive. And so if you're 46 and you go to your doctor and your doctor tells you you're too young, print the Google definition of menopause and the normal ages and show it to your doctor, and then say, do you still think I'm too young? Because that's really patronizing, especially when you're suffering and you're seeking help. Um, and the thing is, unlike many of the things that we treat in medicine, there's not a single test you can order that can say, yes, you're in menopause, or no, you're not. And that makes it harder for clinicians. It's harder for patients, because it's kind of a clinical diagnosis. You've got to get down in the weeds and talk about what's actually happening. And that's difficult sometimes.
And we're going to talk in our next series about the importance of tracking symptoms, tracking your period, tracking I was constipated this day, I was angry this day, because then you're more informed when you go and talk to your doctor because you have a bit of your own history. So there are lots of apps out there. You can track it on paper, etc., in a spreadsheet. So we'll certainly get into that. But
Hmm.
I this is one thing I struggle with as well because I for years I've been asking my GP, please test my hormones, please test my hormones, and now they're saying, no, we're not doing it anymore. And I'm so
Yeah.
confused. I said, well, why? Is testing your hormones not helpful to know where you are in perimenopause or menopause and your estrogen levels and your FSH, etc. So are they not helpful in not, I guess, figuring out if you need hormone replacement therapy? And can
Right.
they not confirm this? I know you said there's really no magic bullet or test you can take, but why are we not testing?
Okay. Well, this is the number one question. This is such an important topic. So there's really a lot of sides to this. Um, the way I kind of describe it is perimenopause is chaotic. Like nobody has the same experience. So, and it changes day to day, hour to hour, different parts of your cycle. So when you go and get your blood work drawn, it's a snapshot. So it's kind of like going to a movie, taking a picture of the screen and saying, "What do you think of this movie?"
Mm,
And and you're missing the picture. And even if you take a picture every 10 minutes, there's still a lot of information that's being left out. Now, it isn't that it's not valuable at all. It's just misleading to tell women that we can test all of your hormones. Like since all of this started, there's companies that will take, $400 or $500 and test your saliva or your urine or whatever and give you this personalized hormonal profile that they then, you can get tailored hormones. That's not how it works.
mm,
It's you're trying to stick your measuring stick in a hurricane and come out with like, oh, you just need this much estrogen and this. No, it doesn't work that way. But let's say you're in your 40s and you're trying to figure out if you are fertile,
mm,
then an FSH, that follicle stimulating hormone we talked about, measured in the beginning of your cycle, can give us a good indication of your egg reserve. Because if your FSH is really elevated, it's kind of like your brain is screaming at your ovaries to make eggs, and your ovaries are kind of going, yeah. And so your FSH is one of those indicators, but it can be up and down in perimenopause as well. The other pitfall, besides the fact that it doesn't give us the whole picture, is let's just say you are having loads of symptoms of menopause and you go to your doctor and your doctor says, let's measure your hormones. And they all come back in the normal range because the range is big.
yeah.
Then does that mean that everything you're experiencing is made up because your hormones are normal? So the other side of it is it can lead to women being dismissed
Oh, okay.
when there actually is a problem because there is no normal for hormones when you're in perimenopause.
Mhm.
Now, I do blood work on my patients, but I don't necessarily do a big hormone panel. Like this is part of what I call outside work. So, Jen, you come to see me as a patient, you've got a laundry list of perimenopausal symptoms. There's overlap with thyroid disease,
Mm,
B12 deficiency, anemia. So, making sure that people don't have abnormal thyroid, their B12, maybe vitamin D, checking their iron. Women are gaining weight, doing some metabolic screening for diabetes. Um, those sorts of things can be really important and helpful. Like I've had patients that I thought, oh my gosh, you're in horrible perimenopause, and get their thyroid test back, and it's actually hypothyroidism. And when you treat that, their symptoms go away. So it's important more so to, because menopause is almost a diagnosis of exclusion. Like you want to make sure there's not other things going on. But then at the end of the day, it's often hormones. But blood tests don't help us determine if you need hormones or how much hormones you need. So, what I encourage my patients to do is what I call inside work, where you have too many of us are so disconnected from our bodies. But
mhm.
when you're going through menopause, your body is communicating with you. So, if you can just tune in and listen to what your body is saying and trust it, And that's why record keeping is so important, because when I was going through menopause, I couldn't remember what I had for dinner last night, let alone what the pattern is in my symptoms. And a lot of women don't recognize that their rage only comes in a 5-day window every month. So if you can use an app, we'll have some at our next one, but basically, if you just keep a really simple journal, how did I sleep? How was my digestion? Was I angry, happy, moody? All of those things, and keep it in track with your cycle. And even if you don't have a uterus, excuse me, and you're not getting your period, you're still cycling as long as you have ovaries. So you can start to see patterns.
Mm.
And then if you can bring that history to your doctor and show them that, look, this is hormonal because it comes and it goes. I'm only ragey for these 5 days. Do I need to take an antidepressant every single day, or is this perimenopause? It can be so helpful, but it also helps you to get in better tune with your body. And, that's a real issue that a lot of women aren't doing. And it also allows you to be your own self advocate.
Mhm.
Because if you know what's going on with your body and you're informed about what's happening to you, you're not going to be as easily dismissed. And maybe you'll ask for that referral, or you'll seek help somewhere else because you know yourself that something's different with your body. And even if your doctor says, nope, your hormones are fine, nope, you're too young, you've done the inside work to kind of appreciate what's happening underneath it. Um, and the last thing I'll say about that is, advocating for yourself is, yes, we do need to talk about the risks of hormone replacement therapy, and we will, but there's also the aspect of the risk of doing nothing about menopause. And there is a risk to not treating menopause, and it isn't just the women who suffer. I mean, they suffer primarily, but it affects everything else about their lives. So I think it's a really serious topic, but don't hang your hat on blood work. And if you can't afford a saliva test, let it go. It's not that helpful anyway. Your body's already telling you what it needs to tell you. It's just a matter for you to tune in and keep track. And that's probably one of your best tools, especially in perimenopause, to be honest.
And I think your body's probably always telling you whether or not you're in perimenopause or menopause. But we're like, I know for myself, I'm always seeking external to say, how, can I do this? Will this help me? Or what's this toolkit? And all of those tools are helpful for your toolkit. But yeah, doing that
Well,
inner work, I think is important as well.
you're absolutely right. And you just reminded me of another point, that most of us tend to immediately look to our environment for what we can justify it with. So if you're anxious and overwhelmed and not sleeping and not coping, well, my job is stressful, my kids are this, my parents are this is happening in my life. Well, I want to remind all women in their 40s and 50s that you've probably coped with a lot in your life. So maybe don't decide that suddenly in your 40s you've lost your ability to cope. The answers aren't always out there.
Yeah.
They're most often in here. And I think that's a really important point, because we blame everything that's going on in our lives, right? I did it.
Yeah, 100%.
Yeah.
I think also, when we talked about symptom tracking is important, but no, uh, so from when it comes to hormone testing, maybe no hormone testing, but don't forget about the iron and your thyroid and your B12 is what I'm hearing you say. So
Yeah.
some testing, but not necessarily hormone testing. So
Yeah.
advocate.
And then there's things like,
Absolutely.
when you're talking about putting people on hormones, and we'll get into this more next time, it's, you know, mammogram,
Yes.
smear, bone mineral density, cholesterol test. What's your risk for heart disease? What's your risk for breast cancer? It's like managing your risks and preventative medicine. Menopause is a perfect time to take stock of your health, and to start to recognize what things you need to do to live as healthy as you can in these decades after menopause. I mean, we live long enough now that most of us spend almost half of our lives in menopause. It's not insignificant.
Right. And didn't you say menopause is never done?
Menopause, people say, how long does it last? And I always say, menopause is forever. And once you're there for good. The only way you get out is to take a dirt nap. Like, it's the rest of your life. So,
Yeah.
and that's why this should be such a hugely important topic if we would like our population of women to be healthy, happy, and thriving. because yes, statistically, women live longer than men, but
Mhm.
we also live poorer quality of lives, and that is important.
Right. And I think women are also starting to realize, well, I have ever since I turned 40 is okay, health is important. I need to, what
Yeah.
I'm ingesting, how I'm moving my body, how I'm advocating for myself, etc. So,
You
wow.
can't get away with what you did in your 20s anymore,
No,
unfortunately.
no.
No,
And if I could tell my,
exactly.
yeah, exactly. I think I posted this the other day. If I, what I could tell my 20-year-old self is eat healthy and don't stop lifting weights. Those are the two things.
Oh, exactly. And
Whole
yeah,
other
that's an
topic.
important topic for next time too. There's so much to talk about menopause. Like
Yeah.
seriously, we could sit here for 4 hours.
Right. And this feels like a really good place to wrap up our discussion because you're right, it is a huge topic and you're committed to doing a couple of these, so we're super grateful. So what's up next? What's up in part two? What can we look forward to?
Well, I think what we should do is dig a little bit deeper into the Women's Health Initiative and what we've learned, and give a little bit more detail on the questions that a lot of women want to know because of the environment around menopause, like things like what are the risks, and what about breast cancer? What about heart disease? What type of hormones should I take? What's the difference between bioidentical and non-bioidentical? If I start it, how long do I stay on it? Do I have to stop it after a certain period of time? My doctor doesn't want to talk about it. How do I prepare to have this conversation with my doctor? What's my package I need to put together to make sure that I get good menopausal care? And because that's such a huge topic, I actually think we're going to have to do part three, which
Okay.
is more like I like to divide menopause care between outside work and inside work.
Uh,
And, it's not that I'm presenting hormone replacement therapy as the be all end all. This will fix everything and make your life okay. It's not magic.
right.
That's one aspect of menopausal care. It's a hugely important one, but there's also a lot more inside work to be done. And that's one of my favorite things to talk about. Like, how do you treat your body? How do you view your body? What does your brain tell you about your experience of this? How do you talk to yourself in your own head? Are you your own best friend? Do you love and care for yourself?
Mhm.
And I know from my own personal experience, many women suffer with lack of self regard. That's an epidemic. And it isn't as easy as saying, well, just you have to love yourself. Like, sure, easier said than done. But there is a path forward there. And I think if women really want to get through menopause in a healthy way and thrive, they've got to do both outside work and inside work. And Western medicine doesn't really address inside work. And, so I think that's where I'm a little bit different because I've had to do it for myself in order to get through the whole thing. And that's why I called my group DeadLadyBalls, by the way. This might be a funny note to end on. I was in the surgeon's lounge years ago when I was going through menopause, and I said, my I have dead ovaries. Like one of the surgeons made fun of me for having hot flashes or something, and I was like, yeah, my ovaries are dead. And he was like, your ovaries are dead, you're young. And he's like, in my house they're called lady balls. And I said, well, I have dead lady balls. And I was like, oh my god, that's brilliant. And then I thought, dead lady balls, my lady balls had to die so that I could live the transformative power of menopause. So I just thought it was funny, and I sort of use a lot of humor to do what I do. And it's not everybody's cup of tea. So if Dead Lady Balls makes you go, it's probably not the group for you. But if like humor is helpful and a supportive community, like I don't post a lot, but a lot of women are answering questions and replying to each other in the comments. And it's just really nice to see that community coming together. So I really appreciate you taking the time to help me do this because everybody in my group knows I suck at social media. I don't know technology, and I can't let that stop me from getting this message out. So I appreciate your time so much, and I'm really looking forward to doing this again.
Oh, me too. And I appreciate you so much. I have learned, like I said, so much in the last couple of weeks, couple of months since we've known each other. And I really look forward to our next session, especially how do you prepare for your doctor? How do you prepare for that 6 minute visit? So thank you for taking the time just to share this critical information with us today. I know we're just scratching the surface, and I just really look forward to it. So have an amazing day.
Perfect.
And
You
thanks again,
too?
Dr. Tracy. All right.
No